Welcome, everyone. Welcome to In Motion Against Clot, the Power of Mechanical and Pharmacological Thromboprophylaxis. It's a great pleasure to be here today to have a great discussion on a controversial topic. We will have questions at the end of the presentation, so please feel free to use the chat features, and I'll monitor that during the presentation, and then we'll generate a good discussion during the Q&A in the last 10 minutes of the presentation tonight. So my name is Marc Carrier. I'm one of the hematologists at the University of Ottawa and president of Thrombosis Canada. And it's a great pleasure to have very distinguished faculty members with me today. We'll start with Dr. Charissa Cordon. She has 2 decades of experience in healthcare as a nurse, educator, and leader. She is currently the Director of Professional Practice and Clinical Resource Team at Trillium Health Partners in Mississauga in Ontario, and she has a wealth of experience as a transformational changes leader in nursing and professional practice. And she has led many initiatives at the local, provincial, and national level, so we're hopeful to be able to get her insights on how to incorporate these changes in clinical practice. So welcome, Charissa. Our second panelist is Professor Nicholas Leyland. Dr. Leyland is a professor and chair of the Department of Obstetrics and Gynecology since 2010, and he also has graduated from Harvard University with a Master's of Health and Master's in Healthcare Management. So welcome, and I'm very excited because the two of you will provide a different perspective to our audience, which are usually using mostly hematologists, general practitioners, vascular doctors practicing in thrombosis and venous thromboembolic disease. So it'll be excellent to have your perspective on things. So these are the disclosures of the participants, or the panelists, I should say. And this program has received financial support from Cardinal Health in the form of unrestricted educational grant. This program has not received any in-kind support. The presenters are eligible for honoraria from Thrombosis Canada, and Cardinal Health may benefit from sales of a product that may be discussed in this program. The content of this program was developed by the planning committee, so Nick, Charissa, and I, and has been peer-reviewed by Thrombosis Canada. Recommendations, as usual, involving clinical medicine are based on evidence that is accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations or conform to generally accepted standards. Now, let's turn into the learning objectives. So at the end of the program, what we would like to do is make sure that the participant can identify surgical patients at high risk of postoperative venous thromboembolism, and we'll focus a little bit with Nick on gyne-oncology patients. We'll assess the underlying risk of VTE and bleeding complication as hospitalized medically ill patients. Can we identify patients at maybe even a higher risk of having VTE, and how do we manage thromboprophylaxis in that certain setting? We'll discuss the benefit of pharmacological, mechanical, and combined thromboprophylaxis strategies in these different populations. We'll provide clinical management aligning with recommendation, mostly from the American Society of Hematology, but we'll also use guidelines appropriate to specific patients. In this particular, in case 1, for example, specifically the Society of Obstetricians Gynecologists of Canada. And then we'll have an assessment with Charissa on how can we incorporate these and to make changes in our own centers. So I'll do a little bit of background just to make sure we're all starting on the same foot and that we can move forward to the cases. Obviously, hospital-associated venous thromboembolism is something that is very important, something that is a leading cause of preventable hospital-associated morbidity and mortality. As you know, PE and DVT occurring while in hospital can create a lot of morbidity and mortality during the hospital, but keep in mind that a majority of cases will be diagnosed within the 30 or 90 days following the discharge from hospitalization, therefore highlighting the importance of having a really good thromboprophylaxis strategy while patients are admitted to hospital. We all know that PE is associated with 10% of hospital deaths. And it's important not to forget that 50% of people that had pulmonary embolism or lower extremity or upper extremity deep vein thrombosis have long-term functional impairment with post-thrombotic syndrome, for example, post-PE syndrome, sometimes chronic thromboembolic pulmonary insufficiency as well. So thromboprophylaxis is really something that we need to consider in order to decrease the morbidity and the mortality associated with it. We have different strategies that are effective. It can be mechanical thromboprophylaxis, it can be pharmacological thromboprophylaxis. It can be a combination of both. So when to use what will be important. Now, obviously, when you look at the patient population in hospital, it's quite diverse and heterogeneous. There's surgical patients, there's medical patients, there's patients requiring critical care. So how is the VTE prevalence fluctuating between these different subgroups? Well, there's no doubt that post-surgery, certain subgroups are a higher risk. We know orthopedic surgery, for example, will be at high risk of having lower MDVTs and PEs if they don't receive thromboprophylaxis. We know neurosurgery patients also have a very high risk, especially in the setting of cancer, of having venous thromboembolic complication. But that might be balanced with a risk of bleeding that is a little bit different, and we'll need to assess the risk-benefit ratio accordingly. Obviously, high-risk postoperative states include bariatric surgery, and sometimes we want to provide thromboprophylaxis in that patient, even beyond the hospital stay. And something that we'll focus on tonight is gynecology, with rates up to 3 to 4% in cervical cancer, up to 9% in endometriosis cancer, up to 40% in ovarian cancer, making the tumor biology very hypercoagulable. On the medical sides of things, most patients admitted to hospital will receive some form of thromboprophylaxis, mostly pharmacological thromboprophylaxis. But what are the additional risk factors that may increase the risk further, for which maybe we should tailor thromboprophylaxis accordingly? For example, patients in critical care, patients with additional comorbidities. All these things are important to consider when we make a decision about pharmacological thromboprophylaxis, mechanical thromboprophylaxis, or a combination of both. Now, why are patients in hospitals so at high risk of hypercoagulable state? Well, they all have the different component of the Vicos triad. They have stasis because they're often have decreased or slow flow. So there's venous stasis that can lead to inflammation. They often have vessel wall damage due to endothelial cell if they have surgery, for example, and they are hypercoagulable. And when they're hypercoagulable, it could be because of underlying disease like cancer, inflammatory bowel diseases, for example, or it may be comorbidities that they have, or just baseline characteristics. Obesity, age, all these things will increase it. And therefore, our patients are very high risk of having venous thromboembolic complication during hospitalization. If they're high risk of having VTE, no risk of bleeding, then we usually initiate pharmacological thromboprophylaxis. If there's bleeding or high risk of bleeding, then it's mechanical thromboprophylaxis. Usually there's two different types: graduate compressive stockings, which will increase blood flow, minimize venous distension, and hopefully decrease the risk of venous thrombosis, or IPC, or intermittent pneumatic compressions, which will increase venous return and increase fibrinolytic activity while clearing blood beyond the valve cuffs per se. So these are the different things that we can use. And then we may ask the question, what about combination of pharmacological thromboprophylaxis and mechanical thromboprophylaxis? Is there a need in certain patients for that? So when we think about thromboprophylaxis in the hospital, we like to divide things about hospitalized medical patients. Obviously, we tend to provide pharmacological thromboprophylaxis. Maybe we'll have higher risk patients, like patients admitted with stroke, patients requiring critical care, patient requiring active cancer. Could these patients benefit from a mechanical in combination with pharmacological thromboprophylaxis, for example? We'll review the evidence of that in the second case. And maybe in order to help clinicians to stratify the risk, it's important to review the risk factors, but that's sometimes hard to keep in mind, or it's easy to forget. And risk assessment models have been developed to help guide clinicians about the risk factors and providing a stratification according to the underlying risk of having VTE complication. This can identify the very low risk of patients that may not need thromboprophylaxis at all, but also may identify a very high risk of thromboprophylaxis for which pharmacological, mechanical, or combination may be required. And obviously, there's always the flip side about bleeding risk. We'll talk about a risk assessing model trying to help predict bleeding in hospitalized medically ill patients. We don't have great validated tools, but we'll briefly look at what we have for the time being. Now, although some of the scores have been derived and validated, they're not overly used in clinical practice, and there's a lot of variation. But I'll show you two different scores that are often used by medical doctor in patients with hospitalized with medical illness. And the reason why I'm showing you this is not only that they can stratify the risk of having VT complication, but you can see a list of risk factors, and the risk factors are very common or very similar from one risk assessment model to the other. Previous VTE, non-thrombophilia, current cancer, active cancer, immobility, limb paralysis, critical care stay, and age are all known risk factors for hospitalized patients. And independent if you're using the improved VTE score, the PADRA score, you can see there's a lot of similarities. And therefore, although these may be derived and validated, they haven't shown to change clinical practice, but I like to use these scores because they remind me of the important risk factors to consider. And when these scores are starting to pile up, it's important to consider thromboprophylaxis and maybe use different strategies accordingly. On the other side, when you're talking about medically ill patients, about bleeding, there's the improved bleed score, again, derived, somewhat validated, not incorporated in clinical practice. But again, the bleed risk factors are important to remember. Recent bleed, thrombocytopenia, age, severe or moderate renal failure, admission to the ICU, sex, all of these things will increase the underlying risk. And as a clinician, you and I needs to keep that in mind when we make a decision about pharmacological, mechanical, or combined therapy. On the surgical side, the Caprini score is quite well used. Again, there's a lot of different risk factors, but interestingly, there's a lot of similarities between the Caprini score that is often used in surgical patients and those used in medical patients as well. So that'll be important to keep in mind as we're going through the different cases. So independent if you're a surgical or medically ill patient, when we think about thromboprophylaxis, I think the things to consider is assess the underlying risk of venous thrombosis. And if the patient is not at high risk of bleeding or bleeding, then pharmacological thromboprophylaxis. If the patient is bleeding or high risk of bleeding, then mechanical thromboprophylaxis until that bleeding settles, and then consideration of pharmacological thromboprophylaxis. And in certain special population at really high risk of VTE, maybe combination therapy may be something to consider. And we'll go through two different cases to highlight with you today. So I'll pass the reins to Nick.
Thanks very much, Mark. So I'm going to talk about some tragic complications post endometriosis surgery. And this is about a 32-year-old woman who underwent surgery to remove an ovarian cyst. And unfortunately, it resulted in the removal of the ovary as well. But preoperatively, they had high CA-125, indicating many benign situations, but also potential for ovarian cancer. The pathology did return as endometriosis. And then following, because the patient did desire fertility in the near future, they were followed at a fertility center. But with endometriosis, often these patients will experience significant pain. Later on in June, she was prescribed letrozole to increase ovulation, and it does increase estrogen levels to allow for ovulation and improve fertility. But it does have the risk of stimulating endometriosis and ovarian cysts. So later on in June, the patient presented with considerable acute pain and was advised by the fertility clinic to suppress ovulation at that time by taking an oral contraceptive, and was also treated with oral narcotic medications. Later, she presented to the emergency room of the same hospital as her original procedure with a significant complaint of pelvic and abdominal pain. She was treated with IV fluids, analgesics, and on imaging, they found a repeat large mass posterior to the uterus, and noted that her hemoglobin was now 86. Platelets were normal. She was given narcotics and because they felt that she was very constipated, especially with the use of narcotics previously, lactulose, and subsequently was discharged. A week later, she returned to the same hospital with severe pain, and it was not relieved by any of the medications that she had been given. She was given IV fluids and narcotics. Her hemoglobin was now 75, not certain if it had been dropping or if there was evidence of abdominal bleeding. And they found that the mass was multiloculated, a large mass up to 15 centimeters, and larger than on previous imaging. And they also noted bilateral hydronephrosis. She was admitted to hospital by the gynecologist on call. She actually received 2 units of packed red blood cells in preparation for placing her on the surgical list as an emergency. The gynecologist on call performed a laparotomy and found a very large mass filling the pelvis and the lower abdomen. And the mass could not be easily mobilized and was thought to be retroperitoneal and very atypical for endometriosis, but and the concern that it was possibly a malignancy, despite the fact they had the previous pathology. She felt the patient was, or the gynecologist felt that it was high risk for bleeding based on the findings at surgery and her history. And the decision was made to close without removing the mass. And at no time were anticoagulant or mechanical VT prophylaxis administered. Postoperatively, she was seen in the morning by the gynecologist who did the procedure, but later in the day, the patient reported dizziness and had a syncopal episode requiring assistance to return her to her bed. The nursing staff noted that her SATs had dropped to 88% and she was tachycardic. The gynecologist on call was paged but did not respond immediately because they were in surgery. And her SATs 95% on supplemental oxygen, but she remained tachycardic. And during the afternoon, the gynecologist on call was apparently not called again. The tachycardia persisted, the SATs fell to 93%, and about 15:30, she became dizzy and collapsed. A code was subsequently called, and resuscitation started, and a PE was then suspected, and TPA was started. Unfortunately, despite aggressive treatment, the patient died during the resuscitative measures. So, and on the postmortem, they found a large saddle pulmonary emboli. So the question that arose, and what you could think about, is really, what would you have done in terms of thromboprophylaxis, and when could it have made a change? So after the first surgery, oh, here we are, we do have the poll up. So a bit of a variation in what people felt. And in fact, obviously, in this case, certainly after the subsequent laparotomy, but in all likelihood, this patient would have benefited from after the first surgery and subsequent laparotomy. What would you do if you were concerned about the risk of hemorrhage? Use both pharmacological anticoagulation, mechanical prophylaxis, calculate the risk of hemorrhage and determine which approach is most appropriate, or use only mechanical prophylaxis? Yeah, I would say that the correct answer really is to determine the risk. And as Mark was saying, there are tools that we can do that. Now, on the basis of the judgment of the surgeon, they thought that she was at risk. But even so, if you don't use a tool, mechanical prophylaxis is the direction that you need to go in. And As Mark alluded to, this was our guideline that we published with the SOGC. And I just want to create a shout out to Dr. Katie Taffler and Anita Courier, and our research person, Nicole Gervais, and the hard work that they did in creation of this guideline. So, and we create these guidelines and make recommendations. And basically, thromboprophylaxis should be implemented based on the preoperative risk assessment as described in the guideline. And for most patients, mechanical prophylaxis is recommended with or without pharmacotherapy based on risks and anticipated benefits. So we have to understand what the risks of VTE are, but also what the risk of hemorrhage are for the particular patients. So utilization of a tool to determine that can be extremely helpful. So for case one, this case, the quality review was performed, and the admitted gynecologist indicated on admission that they did not consider the patient at risk for VTE. I mean, she was young and basically healthy, but there were risk factors based on her history. In addition, no pharmacologic VT prophylaxis was used due to the perceived risk of postoperative hemorrhage. So, and they described the results as issues. I described them as opportunities. So whenever we're reviewing cases like this, it's not really trying to blame or shame people, but just really trying to make life easier for them in the future so that they can make the right choices clinically. So but they did fail to recognize the risk factors for VT phenomena and didn't calculate the risk for a hemorrhage. Failure to consider either pharmacological and or mechanical prophylactic measures for the laparotomy, and a failure of the team to recognize and respond appropriately to the postoperative symptoms of VT phenomenon or pulmonary emboli. And we do use the Caprini score for surgical patients that Mark had put up in our guideline due to the value, I think, of the information, making it easier for clinicians to calculate the issues. So in a Cochrane systematic review, pharmacologic thromboprophylaxis and intermittent pneumatic compression versus IPC alone. So the evidence suggests that combining IPC with pharmacological thromboprophylaxis compared to IPC alone reduces both the incidence of PE and VT and DVT. But based on the statistics and the numbers required to achieve this, the numbers, PE is still rare. It's low certainty evidence, but adding pharmacological thromboprophylaxis to IPC increases, obviously, the risk of bleeding. And pharmacological thromboprophylaxis and IPC versus just thromboprophylaxis alone. Here, it reduces the incidence of DVT and PE as well. So adding IPC doesn't increase the bleeding risk, which is important. And they did look at thromboprophylaxis and IPC versus aspirin and IPC. And we're not really talking about aspirin today, but I mean, in the near future, we'll likely be talking more about the use of novel oral anticoagulant agents, as well as aspirin and IPC when appropriate. Certainly for long-term postoperative management when patients are at home. So the combined review of IPC and pharmacological thromboprophylaxis looked at 34 studies involving 14,000 plus participants, mainly undergoing surgery or admitted with trauma. And all of the, or many of these surgical specialties were included, as well as medical ICU patients. And here we see that with pharmacological thromboprophylaxis and IPC, there clearly is an increase in bleeding risk. Now, in our surgical procedures, we look at all kinds of issues that we can actually mitigate bleeding risk. We used clips for some of the surgical procedures that titanium clips, which aren't going to dissolve over time and increase the risk of bleeding. But we have to look at the acute issues of bleeding. Endometriosis surgery often has very large oozing areas left. So we have to make those kinds of considerations. IPC alone doesn't decrease the incidence of VTE phenomenon as much as pharmacologic plus IPC. But of course, the major risk of bleeding is significantly increased. And here, multimodal thromboprophylaxis, pharma plus IPC versus pharmacologic alone. So we can see that the incidence of PE, DVT, and symptomatic DVT are reduced significantly. But pharmacologic thromboprophylaxis actually improves that, but not as great as the combination of the two. And obviously, the major risk of bleeding is greater when you use pharmacologic alone. So ultimately, when you're looking at the issue of pharmacologic and IPC and aspirin and IPC, we can see the difference here as well. So there still is a lot of research work to be done on the agents involved in how we do it and how we actually select these patients. So the key clinical takeaways. Evidence suggests that combining IPC with pharmacological prophylaxis compared to IPC alone reduces the incidence of both PE and DVT. Combining IPC with pharmacological prophylaxis compared to pharmacological prophylaxis alone reduces the incidence of both PE and DVT. And so the results agree with current guideline recommendations, which support the use of combined modalities in hospitalized patients, limited to those with trauma or undergoing surgery at risk of developing PE or VTE.
Thank you very much, Nick, for providing us with a very comprehensive review and really highlighting that these are difficult clinical decisions, and then we need to make them on a daily basis. And I'll do a second case just to spice things up a little bit and try to add additional comorbidities and see what would be the audience response on or thoughts on type and strategy for thromboprophylaxis. So this is a 69-year-old male post-op day 2 from localized colon cancer resection. Post-op course complicated by decompensated congestive heart failure leading for refractive hypoxia, normal hemostasis intra-op. And unfortunately, he has refractive hypoxia, so he's transferred to the critical care unit and requires intubation. He has a number of previous medical history that can lead to additional risk for both VTE and bleeding. So obviously, he's known to have congestive heart failure, coronary artery disease, additional hypertension, type 2 diabetes, had a previous provoked DVT in 2016 that was provoked following postal knee arthroplasty. You can see that his CBC parameters are reasonable, and he has moderate renal dysfunction with a creatinine clearance of 45 cc's per minute. So then the question after the introduction, the talk with the presentation by Nick, is what type of thromboprophylaxis would you recommend? Would you say no because he's at high risk of bleeding and therefore unlikely to create any good? Should he be on pharmacological thromboprophylaxis only? should he be on mechanical thromboprophylaxis because you're concerned about bleeding risk for a reason or another based on the story I gave you? It could be with intermediate pneumatic compression or graduated compressive stockings. Or are you more favoring combination of pharmacological and mechanical thromboprophylaxis, given that he might be at high risk of having VTE complication? And a number of you would provide combination pharmacological and mechanical thromboprophylaxis using IPC. And then a number of you would say pharmacological thromboprophylaxis only. Excellent. And in order to be able to look at the different options, a lot of these options are good, and there's multiple options that would be very reasonable. So let's have a look a little bit at the data so we can decide on the quality of the data, and then can we make a treatment decision for this particular patient? And we'll try to come up with having a look at mechanical thromboprophylaxis in the ICU, pharmacological thromboprophylaxis, combination. I'll try when I can try to separate the different ICU populations, surgical, medical, and or a mixed combination of all of them. So we'll start with mechanical thromboprophylaxis in the ICU setting. And the first thing that was recently published is a systematic review and meta-analysis looking at mechanical thromboprophylaxis versus observation in patients in the intensive care unit. Now, keep in mind that when we look at surrogate outcome measure in the setting of ICU, we need to use ultrasound detected deep vein thrombosis because ICU patients can't really say if they have DVT signs, symptoms, or PE signs and symptoms. So we usually use that. So when we look at outcomes, you'll see any VTE, DVT, which usually includes symptomatic and or symptoms associated with it, or asymptomatic and PE. And when you look at IPC specifically versus observation, you're looking at the incidence of these outcome measures. You can see that IPC was associated with a lower risk of having these different complications, independent if you're looking at VTE, DVTs, or PEs. When you're looking at the forest plot, you're looking specifically at the incidence of VTE, and you can see a relative risk reduction of about 65% in patients that have received mechanical thromboprophylaxis with IPC versus observation in the intensive care unit setting. When we look at mechanical thromboprophylaxis versus low microwave heparin, there's not a lot of data. The data is really not the one that we would like to see in order to make a decision. There's only one trial that compared low microwave heparin to IPC. This is extracted from a systematic review and meta-analysis that was published in CHEST in 2022. So only 442 patients, small numbers, and again, a mixed bag of different things. But when you look at low microwave heparin versus IPC for primary thromboprophylaxis, there is no big difference in any VTE, DVTs, and PEs, no difference in major bleeding. And for the small number of patients that receive unfractionated heparin compared to IPC, you can see again that there's no big difference in between the two modalities or two thromboprophylaxis strategies. So this is a little bit the rationale for, although low quality, very small numbers, but IPC may be attractive method to prevent VTE in patients that are actively bleeding, those at high risk of bleeding, because for the data we have, it doesn't seem to be lower efficacy and similar safety compared to low microwave heparin in the SCU setting. When we talk about mechanical thromboprophylaxis, are there any differences in the IPC versus the graduate compressive stockings? A systematic review and meta-analysis that was published in Thrombosis Hemostasis in 2020, comparing both modalities, showed that IPC significantly reduced any VTE, and it did not statistically significantly reduce the DVT, but you can see there's a relative risk reduction about 60% there, but it didn't reach statistical significance with smaller sample size, less studies looked at it specifically. When you look at the forest plot on this particular side, you're looking at the VTE event with a relative risk reduction of 50%. So when we think about mechanical thromboprophylaxis, if we want to use it instead of pharmacological thromboprophylaxis, it seems to be working as well, similar safety. So for patients with contraindication, maybe IPC may be something to consider, and that's reflected in the clinical practice guidelines that we'll go through. Now, what about combination, mechanical pharmacological thromboprophylaxis in the ICU? Well, we need to look at different patient population. If you look at patient population in the surgical world, so combination of mechanical and pharmacological thromboprophylaxis, as Nick mentioned and showed the evidence, there's more effects than either modality alone in the postoperative setting. There's a relative risk reduction of about 65% with deep vein thrombosis when you're using combination, and that's using graduated compressive stocking. When you look at systematic review and meta-analysis, 13 trials, 10,000 patients. Keep in mind, though, that there are different patient population that are critically ill. There's medical patients, surgical patients, and mixed patients in that setting. When you compare mechanical plus or combination thromboprophylaxis versus pharmacological thromboprophylaxis, no difference when you're looking at the outcome of DVT. And similarly, when you're comparing mechanical and pharmacological thromboprophylaxis versus mechanical alone, there's, again, not a statistically significant difference between them. So we may be a bit more careful about suggesting combination of mechanical and pharmacological thromboprophylaxis for patient population that are not necessarily surgical in the ICU setting. Maybe we need to have additional risk factors. And you're probably well aware of the PREVENT trials. It's published in the New England Journal in 2019. And then they compared IPC plus pharmacological thromboprophylaxis versus a strategy using only pharmacological thromboprophylaxis. Most patients receive unfractionated heparin. Small subset received low molecular heparin. You can see that independent if you're looking at DVT or VTE, there is no difference in the risk ratio between the two groups. However, they did a priori subgroup analysis specifically looking at heart failure. And then when you look at that post-hoc analysis, there is a relative risk reduction of about 50% in the risk of having deep vein thrombosis if you receive combined therapy. Now, remember that PREVENT trial, about 79% of folks or 80% of folks were medically ill patients, 13% were surgical patients, and only 7% received trauma. So maybe we can extrapolate that more for the medically ill patients, given it was a majority of patients, but there's potential benefit if you have additional comorbidities in the particular setting as published in 2022, congestive heart failure. Obviously, lots of limitation. The limited data is, I've shown you, right, that there's data for families of intervention, mechanical or pharmacological thromboprophylaxis, data on specific intervention, like the IPC, the GCS, the low molecular heparin, and fractionated heparin is more limited. We don't have data on specific patient population. We hardly have any evidence in surgical, medically ill, or trauma. We certainly don't have evidence in obesity, renal dysfunction. It's overall low quality data, mixed ICU population, definition of critically ill patients that are heterogeneous. Outcome includes screening detected VTE, but it's because we don't have much choice. So there's no data that more trials are needed. But in the meantime, you and I still need to make decisions. So what is the American Society of Hematology recommending? Well, they're recommending that if you're hospitalized surgical patient, you should receive pharmacological thromboprophylaxis or mechanical thromboprophylaxis, some form of thromboprophylaxis, depending on the risk of bleeding. If patients are not receiving pharmacological thromboprophylaxis, they should be using mechanical thromboprophylaxis, and if so, they should use intermittent compressive devices over graduate compressive stockings. And for patients who receive pharmacological thromboprophylaxis, combination of prophylaxis with mechanical method is suggested over prophylaxis alone in these patient population. And for those that are receiving mechanical thromboprophylaxis, depending on the risk factors and when you can resume some form of pharmacological thromboprophylaxis, then in that particular setting, it may be desirable to do combined therapy as well when you resume pharmacological thromboprophylaxis. Now, for critically ill and hospitalized medical patients, ASH does not have a particular chapter for critically ill patients. The European Society of Anesthesia is currently doing critically ill recommendation about mechanical and pharmacological thromboprophylaxis. They're doing it in combination or collaboration with the International Society of Thrombosis Hemostasis. Unfortunately, they were not published for the presentation today, so I'm showing you what ASH is recommending, but they're suggesting pharmacological thromboprophylaxis over mechanical in acute or critically ill patients who do not pharmacological thromboprophylaxis. Obviously, mechanical thromboprophylaxis is required. And then if you're using mechanical thromboprophylaxis, you should use, again, intermittent compressive devices. And for if you want to use combined therapy, that should not be done routinely, but some data is showing that maybe if you have additional risk factors, using a combination may be desirable if the risk-benefit ratio is correct. So if we go back to the case, I think there's really two answers that are probably very reasonable. All of them are probably reasonable, but combination pharmacological mechanical thromboprophylaxis giving this is an ICU patient's post-surgical, post-resection or a surgical patient, and pharmacological thromboprophylaxis only was also a very reasonable answer. There's a number of different things that could have been incorporated. I've tried to add the congestive heart failure and things just to increase the underlying risk and maybe raise some flags that maybe this patient is particularly at high risk of having VTE complication. But I think these two answers would have been very reasonable in practice setting. So with that, I'll leave the podium to Charissa.
Great. Thanks so much, Mark. So both Mark and Nick provided us all with the best scientific evidence and best practices on VTE prophylaxis. And now you're probably asking yourself, what now? How can I get my colleagues to adopt the same practices and standardize the practices in our organization? So over the next 10 minutes, I'm going to go over clinical adoption and change management at the systems level. I'm going to describe the change management framework. And so the framework that I'll be talking about is the ADKAR framework. And I'll provide you with some tactics to help drive change at the systems level and some strategies to measure and sustain change. So the ADKAR framework is something that many hospital administrators are familiar with. It's an acronym that stands for awareness, desire, knowledge, ability, and reinforcement. Awareness means that you're ensuring that there's an awareness of issue, and then you would ensure that there's a desire to adopt the change, which means you're incentivizing the benefits and consequences of not doing the change. Knowledge means you're creating an approach on how to create and how to sustain the change. Ability means you're closing the skills gap that would limit the change and ensuring that everyone else can do the change, and you're making it easy for people to adopt the change. And reinforcement means that you're measuring that change and rewarding small wins. So when it comes to awareness, there's some approaches that you can think about. These are, you need to identify who your stakeholders are, in particular, identifying who the decision makers are, such as your administrators, ensuring that your finance department is also on board. Then you need to think about who would be impacted by the change and who would be the implementers. So from a prescribing side, your physician partners would have to be involved. And then the nursing group would have to be involved because they would administer the medications or even the mechanical prophylaxis. Pharmacy would have to be involved because especially if you want to standardize the pharmacological interventions in your organization. Other groups that you'd have to get involved are the decision support department. This is the group that typically creates reports for the organization, or your clinical informatics group or health records group. The other thing that you'd have to think about is creating an awareness and getting this group of stakeholders together to really define what is the problem that you all need to solve and why is this a problem and what would be the risk if you don't solve this problem. And you can anchor the awareness piece with either your mortality rates, your incidence rates, or part of your quality improvement plan. Once you've gotten a group together, you need to get them to understand why this is important and how it's impacting your hospital's processes. How is it impacting the bottom line? Is VTE preventable? Is it impacting the length of stay? And is it impacting patient safety? You'll want to highlight the impact of having variability in practice. Is having different medications available for different population causing medication errors? Is it contributing to patients that are developing pulmonary embolism or deep vein thrombosis in your hospital? You'll also want to highlight why they would want to participate and what would be the risk if they don't. So really highlighting what's in it for them. Finally, on the knowledge piece, it would be important to really highlight what is the change that you need to do. Do you need to standardize your order sets on admission? Do you need to ensure that you've got a standardized risk screening tool? And then you also need to think about how it impacts other disciplines, and how do you ensure that the clinical team knows what to do in managing these patients. Finally, this is one of the most important aspects. It's really thinking about the ability to do the right things consistently. So one thing to think about is, how are you going to ensure that the change happens? Should you have a governance structure? Do you have a policy that's clear and simple to follow? Which guidelines are you following? Do you have a risk score process? And have you standardized your prophylaxis from a pharmacological and mechanical mechanism? The other thing you need to think about is ensure that the clinical teams are able to do what they're supposed to do, and their roles in preventing venous thromboembolism. So you'll have to think about who from your team can develop the training programs. And these are for your physician group, for your learners or residents, for your nursing group, for pharmacy, even physiotherapy could be involved in your VTE prophylaxis strategy. It's important to hardwire your practices to make it easy to do the right thing. So for example, how can you make it part of your day-to-day work? If you've got order sets, think about how you would embed VTE prophylaxis in your admission order sets. And think about how you can include that in your electronic medical record or part of nursing documentation with their flow sheets in assessing patients. Finally, we'll need to think about how we're successful. What are the metrics and targets that you'll have to measure? And how often do you want to report this to the group? Think about an audit. Should there be an audit for, having an order for all admitted patients with a hospital stay of 48 hours? And think about who would receive the report. I think one of the most important aspects is standardizing your practices. One of the key success factors that I've had in the past is in having EMR forced functions with regards to your order sets or VTE risk assessments. So here are just some examples of some admission order sets that was implemented in one of the large hospitals that I worked in. This provides some examples for orthopedic order sets or day surgery order sets. Even in our for patients that are admitted in the medicine program, we had our VTE prophylaxis included in the admission order sets. So we have another poll for you. There's no right or wrong answer here. It's just an environmental scan. Does your institution's EMR force you to consider thromboprophylaxis? Okay, so most of you have an EMR force function, which is great because that actually makes it easy for you to think about the need for each of your patients. For those that don't have EMRs or don't have it forced within your EMR, I would strongly encourage you to think about how to embed this in your day-to-day practice and consider including it in your pre-printed admission order sets, or perhaps have some prompts for some of your coordinators or nurses to prompt it for your patients. Next slide. Okay. So other practical considerations is related to function and access. So one thing is around standardizing the medications. There's actually a lot of administrative value in this. In one organization that I worked at, there were many choices to choose from with regards to heparin versus low molecular weight heparin. And one of the risks that we found out was that nurses actually got confused on which meds to use. And also having a lot of medications can lead to increased financial burden. In other words, you have to purchase a lot of medications, keep it in store. A lot of them expire. So to promote med safety, I would actually encourage standardizing the practices and your medications. Another thing to think about is from a non-pharmacological perspective, which is your intermittent pneumatic compression devices. I would encourage you to, again, include that in your admission order sets. And ensure that it's standardized, and make sure that you have it stocked in your carts. One of the things that I also found out was that sometimes when you have different IPC devices, then you've got different sleeves that don't match the devices. So it's hard for nurses to apply IPCs in a timely manner when they don't have the right supplies, or when they don't have the right sleeves that match the devices. These are simple solutions to think about to ensure that your team is able to administer or apply the interventions in a timely manner. Finally, think about staff training on the equipment, and also train them in the dual approach of pharmacologic and IPCs and when to use both. It's also important to train them on when to escalate risks when needed, especially when your patient's condition changes and with your high risk groups. So this is an example of a daily assessment for nursing that we implemented in one of the organizations that I worked for. This was part of their daily assessment, and we got nurses to ask these questions daily. If the answer was yes, then they know that the patient is at high risk. But if they answer no to any of the above questions, we prompted them to discuss the current treatment modality with their physician group. We also encouraged participation with our physiotherapy group, which helps with patient ambulation and exercise. And finally, we also had a patient education program that teaches patients why it's important and what to report. So signs and symptoms such as shortness of breath, or when they feel that their heart rate is increased, or if they feel swelling and pain in their legs. Again, we would encourage you to anchor the change in your daily work and corporate culture to enable sustainability. Embed some of your targets or performance in your dashboards, and create annual reports that decision makers and clinical teams can understand. So for example, you can have an annual target for your DVT rates or PE rates. You can have a compliance target of a number of patients or % of patients with VTE prophylaxis in their admission order sets, or you can also report on whether VTE prophylaxis was administered within 24 hours of the orders being in place. So in summary, hospital-associated venous thromboembolism is a leading cause of preventable hospital-associated morbidity and mortality. There are a few screening tools that were presented to you by both Drs. Carrier and Leyland. The Caprini score, Padua scoring, improved VTE, and improved bleed scores can be used. It's important to create regular reports that decision makers and clinical teams can understand and respond to. It would be really helpful to have annual targets and compliance rates, and make sure that you're anchoring the practice in your day-to-day processes. So I'm going to pass it over back to Mark to facilitate Q&A. Thanks, Mark.
Thank you so much, Charissa. That was really helpful for us to establish a a program and really a step-by-step cookbook, almost a recipe on what to do. So it'll be very helpful to folks. I'll start with you maybe because Sandeep from Singapore, and we also have a participant from Ethiopia. They're saying that in most Asian countries, I'm starting with Singapore with Sandeep, they do not practice any risk assessment through their hospital policies on, and I guess part of it is also there's a lot of lack of data in different ethno-racial groups. So we do not have the latest data on VTE in the local setting. Also, some of us do practice regularly doing risk assessment of medical condition, and they use ultrasound. And then similarly in the same thing is for Ethiopia, they don't do hospital practice risk assessment. Do you have a first step for them? What would be your suggestion as a first step?
So what I've done in the past was first, I have a VTE physician champion. So let's say I was working with Nick. Nick and I would partner up, and then I would say, hey, Nick, which assessment would be easy for physicians and nurses to do that we would embed in the day-to-day practices, and you know, my physician champion would be most knowledgeable on the different guidelines, like guidelines in Thrombosis Canada or CHEST guidelines, and then we would collaboratively make the decision. So I guess I would ask, that would be my first step, would be to have a partner in making that decision. And so I guess I would ask Nick, what would be your recommendation as well?
Excellent. Thank you so much, Charissa. Just to follow up with you, Nick, a couple of questions. One from Esteban Gendera from Argentina. He was asking, do you use a risk assessment model to predict bleeding post-surgery?
Well, I think the model that you presented is a good one. But with respect to surgeon, the best person to assess that is the surgeon or part of the team, because they know the risks of postoperative bleeding on the basis of how they managed it intraoperatively. So it's a combination of the pre-existing risk factors, but the type of surgery that you do. But I did allude also to the fact that there are surgical techniques that one can utilize to diminish the risk of postoperative bleeding, especially in this particular population. So it's something to consider that I think when I'm training residents, they hadn't thought about, using something that's non-absorbable to deal with the vascular pedicles and bleeding issues.
Right. Thank you so much, Nick. And I'm being mindful of time, but maybe we can talk briefly about two small questions that were brought up, and then just two comments, and we'll call it for a night. But one of the question was what to do in extreme of weight if you're using pharmacological thromboprophylaxis. This is a good question, and we get that question quite a bit. I may refer you to the Thrombosis Canada clinical guide on medically healed thromboprophylaxis, and you have a table with different weight. I mean, it's not necessarily evidence-driven, it's guidance, but you have different weights, the different suggested regimen for the different low max weight heparin. So maybe you can have a look and see if you can apply it to your clinical setting. And there was a question specifically about thromboprophylaxis in the setting of COVID-19 in stable patients, especially long-term care. Is there any need in order to provide thromboprophylaxis in that setting? And then we now know that that risk is very small. And the active 4B study that's published in JAMA, and remember, this was symptomatic outpatients with COVID-19 randomized to aspirin, apixaban 2.5 twice a day, 5 twice a day, and placebo. And the rate of having VT complications over the follow-up period at 45 days was from 0 to 1.4%. So for that particular question, I don't think we need to specifically start some form of thromboprophylaxis if the patient does not require hospitalization. And then lastly, two comments that I thought was very interesting. So Carissa, Leo was listening from Sick Kids, and said that the presentation was really interesting and that he could, obviously with dose adjustment, use some of the insights he gathered today to sick kids. And then Sandeep, after your response, said that he will be the champion, and I guess he'll be a champion not only to Singapore but to the whole Southeast Asia region. So we now have a champion to help with thromboprophylaxis in that setting. And maybe with that, I'll call it for a night. I would like to thank Dr. Cordon, Dr. Leyland for participation. We're very grateful that you accepted to participate and provide insight. We don't get these perspectives frequently on Thrombosis Canada, and I think I learned a lot, and I'm sure the audience learned a lot as well. And then if you're up for it, remember that we have the CanVector Thrombosis Canada conference that is coming on October 25th and 26th in Toronto, and the registration will be open later on this week, so please consider participating. It'd be great to see you there in person. With that, I wish you a fantastic evening. Thank you for participating, attending, and have a great evening everywhere you are.